speaker is Dr. Ronald Hirsch, which I feel doesn't really need an introduction, but I'm happy to do one because Dr. Ronald Hirsch to me is the medical advisor for case managers in our country. He's always there to update us and keep us on top of the newest information so that we could be more effective in our work. Dr. Hirsch also has been a regular speaker for our conference. I believe this is his third or fourth year, and we're so lucky to have him every year. Just a quick housekeeping reminder before I proceed, and that is just another reminder that we are holding all questions to the end of the presentation, and we request that you put them in the Q&A box, and then at the end of Dr. Hirsch's presentation, we'll go through each question and Dr. Hirsch will be able to respond to you. So Dr. Hirsch is the Vice President of Regulations and Education Group at R1 RCM Incorporated. Dr. Hirsch was a general internist and HIV specialist and practiced at Signature Medical Associates, a multi-specialty practice located in Elgin, Illinois. He was medical director of case management at Sherman Hospital in Elgin, Illinois from 2006 to 2012, where he was chairman of the Medical Records Committee from 1995 to 2012. And he also served on the Medical Executive Committee. Dr. Hirsch is certified in health care quality and management by the American Board of Quality Assurance and Utilization Review Physicians, certified in revenue integrity by the National Association of Healthcare Revenue Integrity, and on the advisory board of the American College of Physician Advisors. He's on the editorial board of RAC Monitor. I know I join RAC Monitor every Monday to hear him. He is the co-author of the Hospital Guide to Contemporary Utilization Review, with the third edition published in 2021. Without any longer time, I now turn the program over to Dr. Hirsch. Thank you very much.
Thank you. Pleasure to be here. And let me see if I can work on sharing my screen. We got to do all this technical stuff. I do think that with the current technical issues that so far, oops, now I got to fix this. Hold on. Oh, come on. I think you guys see the half thing, right? Oh, here we go. Hold on. Okay. With the technical issues and with the weather, I think CMSA really should have borrowed the New England Patriots private jet and flown all the participants to Hawaii, where we could have been in person and enjoyed the conference without technical issues. So maybe next year you guys can do that. Let me start by saying I was just listening to the Nova Leap presentation, and that is absolutely amazing. All right. Every single day in every hospital around the country, there are patients who get brought to the ED because the families can't take care of them any longer. And, we take care of them, right? You do your examination, you check things, and you find out there's nothing medically acute about them. They have no need for hospital care. But you're now at the situation like, what do we do with them, right? Half the time, the family actually snuck out the back of the ED and they're gone. And now the patient is there with nobody to make decisions, nobody to take care of them, and you're stuck hospitalizing them. So this is amazing. I just having a resource where you guys in the hospitals can call someone like Nova Leap and say, hey, we've got this family that's on the brink of, falling apart. They can't handle anymore. Who can we go to? What resources are available? Would be awesome, right? Getting a home aide to go in there several hours a day to relieve that patient from the family from the burden would be amazing. So you guys are lucky to have a resource out there in New England. A lot of areas don't have something like that. It's going to get worse. We're all getting older, right? Medical care is getting to the point where people live longer with chronic illnesses, but sadly at the end we're all going to die. So let's help people get through that. Let's not force them to be hospitalized, taking up beds, worsening our um, bed crunch, our ED boarding, et cetera. With resources like that, it's just wonderful. All right. So I live in the hospital world, by the way. I know that there are many case managers that live in the outpatient world, do workers' comp or VA stuff. I'm going to be talking about acute hospital stuff for the most part. So I'm sorry if it's not directly into your area. I will say for many people who live in those worlds, they do pick up tips, things that they didn't know about Medicare that can be used in their work. So I'm going to talk about things that are hot, that's new for 2026. Some of these things I'm sure many of you have heard about, but I like to go into some of the details so that you can master them. So the first thing that came about in 2026 was that Medicare again finalized that they're going to start eliminating the inpatient only list, right? For those that don't know, inpatient only list is something put out for Medicare and Medicare Advantage, where those patients must be admitted as an inpatient and you must submit an inpatient claim or you're giving away the surgery for free, right? They used to look at the list based on the complexity of the surgery, the expected length of stay, the comorbidities that patients have, and decide what should be inpatient and what can be allowed as outpatient. They now think it's that physicians are in the best position to judge who should be an inpatient, who should be an outpatient, who can be done at a surgery center, and they don't need this list, right? So it's going to be a transition over 3 years. Some of you may remember they tried this in 2021, but they made some mistakes. So they canceled that, and now they're doing it again. All right. So 285 procedures this year removed from the list. Most of those are orthopedic and spine procedures, but there's still 1,500 almost that are on the list, right? What that means is you got to know what the surgeon is planning to do. You need to know the CPT code of the surgery that's being planned, right? They may not know it as a surgeon, but their office staff knows it because they're going to send in a bill for the surgeon to get paid for doing the surgery. It's crucial, right? Don't count on them telling you, I'm doing a cholecystectomy, right? Because you need to know if it's an open. Is it laparoscopic? You need to know if there's complications expected, if it's going to be a complex surgery, et cetera. So get the code. Make sure you get the order before surgery, right? You want to get the order in the chart before surgery. The patient gets admitted, um, so you get paid, but also if that patient ends up needing to go to a nursing home under Part A, right, you need to have 3 inpatient days unless you're in one of the waiver programs, right? So you don't want to wait till the day after surgery or the second day after surgery when someone finally says, oh, shoot, this patient's not doing well. They're going to need to go to a nursing home. And now you get the order and now you're going for 3 days to get them qualified. So make sure you hardwire that admission order, all right? I will note if you miss the admission order on the day of surgery or prior to surgery, the 3-day payment window does apply. So if the patient's still hospitalized, you have 3 days to get the order and you'll still get paid for it, right? There is a provision in the Medicare benefit policy manual that I cite here that says, if a doctor does an inpatient only surgery and you forget the order, it just gets through, right? And the patient goes home 2 days later and realizes, oh my gosh, we never got an admission order. You can establish that the physician's intent was to admit that patient as inpatient, and you can still bill for surgery and still get paid, right? I would like to suggest that if any of your hospitals don't have policies in place to get the inpatient order, these surgeries are slipping through inpatient only. When I go onto Medicare and I need surgery, please call me so that I can come to your hospital and get my surgery for free, right? That sounds really good. I'd love an $80,000 surgery for free, right? I want the Medicare Trust Fund to be around. So if you want to give away surgeries, please tell me so I can come. Right. So as we look at surgeries, I want to remind you to make sure that you get medical necessity documented for the surgeries, right? It's not just getting admission order, getting the surgery done, even on the outpatient side. Is there documentation in the record to show the patient needs surgery? It meets the requirements of the Medicare coverage determinations. Even the commercial payer or Medicare Advantage determinations, right? We often have patients get surgery, and when it gets reviewed afterwards, there's no indication they needed it. And I'll give you a great example. It's an extreme one. Um, and that's that we had to do an audit of a knee replacement. And the notes from the surgeon actually said, when we got the office note, patient has osteoarthritis, tried Tylenol, not working. Daughter getting married in 6 months, wants to dance at wedding, so wants knee done now. That was the medical indication for doing surgery. The payer in this case was absolutely appropriate, right, to deny payment for that surgery because they didn't try a thorough course of conservative care. Right. We have prior authorization programs. Medicare is a little schizophrenic with prior authorization these days. On one hand, they say it's a hindrance to patients getting the care that they need. On the other hand, they've put into place prior authorization programs. So it's a little bit of mix, right? The WISER program is starting in January, and that is actually hiring companies to use AI to review prior authorization requests and determine if surgery will be approved. So it'll be interesting to see where that goes, where the government goes with AI use in these situations. I'll also mention with the inpatient-only list that we're getting better with our medical care, and some inpatient-only surgeries remain on the list, but the length of stay has gotten to the point where patients go home the day of the procedure, right? Percutaneous or TAVRs, aortic valve replacements percutaneously are now in many institutions going home the same day, right? Watchman device placements are inpatient only, but going home the same day. They can go home the same day as inpatient, right? Case management shouldn't have to deal with billing, but you often do. So if you get a call from billing saying, wait a minute, we got this inpatient claim and the patient went home the same day as the procedure, but it was inpatient only, we can't submit an inpatient claim because they didn't stay overnight. Well, the answer is yes, you can. Go to the Medicare Claims Processing Manual, read that section. You will see that you're allowed to add a room charge, and we can get paid for performing that procedure and sending the patient home. Likewise, we don't tell doctors they need to keep patients longer just to get us paid more. That should never be an issue, should never happen with any of our patients. All right. Now, the other point with all this is that if it's off the inpatient only list, it can be inpatient or outpatient, right? So again, total joint replacements are not inpatient only, but some of them can be inpatient, right? And how do you know who, right? First question is, how to know whether it's worth your time? Why shouldn't we just do everybody as outpatient, except maybe that one unique patient who does need to go to a nursing home? Well, to know whether it's worth your effort, you got to get your numbers, right? You got to find out what you get paid for inpatient or outpatient. Again, if you think about it, if you're doing a surgery in your hospital, right, and you're treating inpatients differently than outpatients, you have bigger problems, right? We're going to treat an outpatient surgery patient the same as an inpatient, right? Really, it's about how much we get paid for it, right? So, and it can be significant, as you'll see in a minute. Again, with MA plans, you're going to have to talk to your finance team to see what you get paid. There are hospitals that get paid by MA plans via contract as a percent of charges. And what if you get told that your outpatient payment exceeds your inpatient payment, right? If it's an MA plan, why would you accept an inpatient authorization or request inpatient when you're going to get paid more as outpatient? Do it outpatient, take the extra money and run, right? So what about the money? Just looking at some random hospitals I pulled up. You can see on the left a community hospital, no teaching program, right? The differential for them is $2,000, right? Now, $2,000 per surgery adds up, but it's not like the teaching hospital on the right side where it's $15,000 per surgery difference, right? Now, why is there a difference like that? Because teaching hospitals receive what's called indirect education funding from CMS for their patients when they're inpatient, right? So every inpatient admission gets an added payment from Medicare to cover medical education. Based on the number of residents and interns you have running around determines what your payment rate is. So in this hospital, they have a big teaching program, and every admission for a joint replacement is $15,000. When we get up into, more significant surgeries, right? Some of the spine surgeries, it can be $25,000, right? If you're doing something like CAR T therapy, which is moving to the outpatient setting, if you do it as an inpatient, it can be $50,000 in that educational money. So you got to know your numbers, all right? Now, let's say it's non-inpatient only. It's you have a patient and they're Medicare or Medicare Advantage, and you have to figure out what status to make them, right? The doctors don't care, right? They just want to do surgery. So you're going to be guiding them to the right status. So the first question is, what's the expected length of stay, right? How long do people having that surgery stay in the hospital, right? In general, as a standard, right? And if it's more than 2 midnights, you get to make them an inpatient, right? So let's take the time when coronary artery bypass surgery, when there's no inpatient only list at all, coronary artery bypass surgery, everybody stays, right, several days in the hospital. So expected length of stay, 5 days, inpatient, right? I will tell you, by the way, we mentioned MCG earlier. MCG within their guidelines has excellent references that talks about the average length of stay for surgeries across the country from all of their data. So you may have a doctor who does cholecystectomies and keeps their patients 3 days after surgery. And everyone's like, is that right? 3 days? That doesn't seem right. You can go to MCG and you can look up their references and you can see that 87% of patients having cholecystectomy get discharged the same day or the next day. And you can use that to talk to that doctor and say, hey, doc, the standard of care is really same day or next day. We need to help you feel comfortable sending your patients home earlier. All right. Second factor with length of stay is you may have a patient who's having a surgery where the average length of stay is 1 day, but they have comorbid conditions that are going to make them require a longer stay to make sure they're medically stable. All right. So a COPD patient, a heart failure patient, a dialysis patient who's going to have a surgery, right, is going to need steroids afterwards, diuresis, etc. They may need additional time. And if the doctor says, yeah, I'm going to need to keep this patient longer, you can make them an inpatient. Right? The bottom example, the spine surgeon, right, doing a surgery, the patient's on an oral anticoagulant, and the surgeon says, I'm not letting them go the day after surgery. They're on an oral anticoagulant. I'm operating in their cervical spine. And if they start bleeding or swelling, they're going to be paralyzed. I'm going to keep them in the hospital 2 days. Make them an inpatient because the expected length of stay is 2 midnights. The other question is, do they need to go to a nursing home? Medicare has stated, and it says in the bottom, right, we would expect that those Medicare beneficiaries identified as appropriate candidates to receive surgical care in the outpatient setting would not be expected to require SNF care following surgery. So reverse that and say, if a patient is going to require SNF care, they can be admitted as an inpatient and kept 3 days, right? It has to be something legitimate, right? It's not that the wife doesn't want the husband home after his surgery, but the wife can't manage, can't take care of him. They have a bathroom on the second floor. If those are legitimate reasons, you can admit as inpatient, and for Medicare, keep them 3 days so they get qualified for their Part A benefit, right? Medicare knows that the 3-day rule is obsolete, but it's going to take an act of Congress to fix it. So in the meantime, they just have to work with the laws, the rules, the nuances they can to give us the ability to get patients that benefit. And this is one situation where you can do it. Now, obviously, for Medicare Advantage, they don't have the 3-day rule. They waive it. So you can't use that as a reason to admit as inpatient, right? I also like to mention, by the way, when you look at, we talk about SNFs all the time in case management, right? We have these facilities, but I want you to think about a SNF in a different way. A SNF is actually a facility, right? A nursing facility that has a SNF wing, the skilled wing, but also has a long-term care wing, right? So the long-term care wing is a nursing facility. The patients aren't receiving skilled care. They live there. It's their home, right? So you have to keep that in your mind that there is a difference in that. And when you talk about sending somebody like the family who dropped their family member with dementia, who has no skilled cares, we need to send them to a NIF, a long-term care facility. We're not talking about a SNF. So be careful as you do that, right? Because to get covered in a SNF, to get the care paid for, they have to require skilled services, skilled rehabilitation, right? And those are laid out by Medicare, right? They need skilled services on a daily basis, right? Can only be provided in a SNF, again, that skilled wing, and they're reasonable and necessary for treatment, okay? They do say as a practical matter, right? They would consider excessive physical hardship, less economical, less efficient, the ability for caregivers, right? That is laid out in the Medicare Benefit Policy Manual. So again, an elderly patient having a joint replacement who's cared for at home would be cared for at home by their spouse, but their spouse has dementia and or has lots of medical problems and they can't provide the necessary care, we could send to a SNF. Okay. So understand that, right? And again, use that terminology correctly. So when we're communicating about who's going to pay for it, right? SNF care is often paid for by the payer. Nursing facility care is long-term care and again requires long-term care insurance, self-pay, Medicaid, other programs to help cover that cost. All right, jumping back to the inpatient only list changes. The next decision about whether you can admit them as an inpatient is based on what's called the case-by-case exception that Medicare adopted several years ago, right? So this is for a patient where the doctor expects them to go home the day after surgery, but they are higher risk, right? So 1 day expected length of stay, but due to the history, comorbidities, severity and signs and symptoms, or risk, the doctor thinks they should be made inpatient. And this is again where we have to, as case management professionals, look into the patient's history, understand their comorbidities, and help guide the physician to the right status, right? So the plan is that they're going to have surgery and go home the next day. But if they have comorbidities that raise their risk or the surgery will be technically difficult, we can get them made inpatient. The doctor can admit them as an inpatient. And again, same care, we're going to be receiving the same monitoring, but that monitoring is going to be more extensive. It's going to cost more, so we can admit them as an inpatient so the hospital gets that extra money. I'll tell you, you got to have documentation, right? And I think all of you know surgeons don't like to document, but they have to, right? So we got to get them to do it or work with their PAs and NPs in the office who do a lot of the documentation for them to get these things documented, right? And it's not a lot, right? Due to COPD, heart failure, and diabetes, this patient's at high risk for surgery and warrants inpatient. Right? Due to significant adhesions from multiple previous surgeries, this laparoscopic cholecystectomy will be complex and warrants inpatient. Right? A note there, right? It must be clinically valid, right? The doctor can't write all that, and then you go look at the medical history, and they don't have COPD, or they're not even on medications for their diabetes, right? So it has to be clinically significant, right? I'd love to say that there's easy guidelines that somebody has come up with a list of diagnoses that fit here. There isn't, right? It's going to be a physician determination, right? I like to say that when the surgeon is in the office with the patient preoperatively, they are reading the chart and they are thinking to themselves, oh my gosh, look at all these medical problems. This guy's going to be, potentially a train wreck. Or they're looking at the x-rays or their past surgical history and they're saying, oh my gosh, this is going to be a tough surgery. I'm going to make sure I book him when I'm, early in the morning so I'm not tired after a full day in the OR, right? So they're thinking it. We just need to get them to tell us that this is going to be a higher risk, a more complex surgery. So we can get them to document it. We can get the inpatient order preoperatively. We can get that added reimbursement. If you're talking to your surgeons, you may want to suggest to them, doc, by getting inpatient, the hospital does get paid more. It covers the cost of that patient's care, but it also helps cover the cost of all your tools in the OR, right? When the surgeon wants a new robot or a new laser or whatever else is coming about, right? They can go to the surgeon, go to the CEO and say, hey, doc, excuse me, hey, CEO, I document great. Look at all my inpatient surgeries that get paid, right? I earned you the money that can help you afford my new tool. So let's work together. Let's improve the care at this hospital. I'm helping you document well, status well. You can help me by getting new tools in the OR. And don't forget, if you're doing an outpatient surgery, they weren't high risk, they wasn't complex, but the day after surgery, the patient's not ready to go home. They're still in pain. They're not ambulating enough to go home, right? They have a complication. They're bleeding. Their hemoglobin's dropping. Their sugar's elevated. If they're staying a second midnight for necessary care, you make them an inpatient, right? Don't forget those. The 2 midnight rule says if they need medical care after the second midnight, we admit as inpatient. And that'll also get you that added payment. Okay, so that's inpatient only. Let's talk about another thing that's happening that may be new hitting some of you. The patient comes to the emergency department, right? They get called to be admitted as an inpatient, right? Naturally, probably the hospitalist on duty, right? The hospitalist is going to call some consultants. The patient gets seen, they get cared for. 5 days later, they get better. They go home with their discharge instructions. They're told to call all their consultants to get appointments, right? I think we all do that. We want to make sure they get seen, get the care they need after they leave the hospital. But what happens? They get home. They call the consultants that they saw in the hospital. And that consultant is not part of their insurance network. They get told, wait, you have Aetna? We don't accept Aetna. We can't see you unless you pay cash and we want $500 up front for a visit. What does the patient do? They don't pay the $500, right? Maybe they go back to their primary care if they have that, right? Or maybe they just don't make the appointments. And then when they get sick again, because they didn't get their follow-up care, they didn't get their medication adjustments, they come back to the hospital, they get readmitted, you get penalized, and you get yelled at because we have a readmission problem, right? I'm sure that happens all over in hospitals, right? Because generally what we do is we have a list of on-call consultants, or we have the hospitalist using their favorite consultant, but nobody looks at the insurance. I remember in my private practice, I had a patient who ended up going to the ED because they fell on a weekend and broke their wrist and they got splinted and they got told to call the orthopedist office. And they were told the orthopedist was the doctor on call for that day for the ED. They weren't in their insurance. And they call me and say, what am I supposed to do? I've got a broken wrist. I'm supposed to see an orthopedist, but they're not in my network. Right? We had to find them someone in their network so that they could see it. So what's happening and why I'm discussing this is Anthem came out with a policy starting this month that if a hospitalized patient receives care from a non-participating provider, right, at any point in their hospital stay, the hospital payment will be reduced by 10%, right? So that could be the cardiologist, right? The pulmonologist, the ID doc, the hospitalist, right? The pathologist who reads the specimen, right? The radiologist, the ED doc, right? Any non-participating physician part of that care, the hospital now suffers a penalty, right? Now, the hospital is going to be upset about this, right? Because they're going to say, wait, we have a medical staff. We can't tell them who's going to be on, that they have to contract with a payer, but maybe it's time something gets done. So what's going to happen with this? I think as C-suites start seeing this happen, getting the reduction in payment, who do they go to when there's a problem in a hospital, whatever it may be? They come to case management. And they said, case management, it's your thing to fix, right? So we're going to have to figure out probably. Now, first of all, you should say, no, that's not my problem, right? But you know how it goes, right? So we need to figure out how do we figure out who's in network with each payer? so that we do get the right consultants on the case, right? The hospital, obviously, you can't fix who the pathologist is or who the radiologist is. But again, if you have an open medical staff, you're not all employed doctors, right? You need to figure out who is in Aetna, who's, in Anthem, who's in Blue Cross, right? Not only, again, is it going to help the hospital maintain their payment, but it's going to help the patient get the care they need after discharge, right? So if this hasn't come up at your hospital, watch out for it. Someone's going to get those phone calls. All right, next issue. Some of you may be aware that the PEPR is back, right? The PEPR is the Program for Evaluation of Payment Patterns Electronic Report. It's a report put out by Medicare on a quarterly basis to allow your hospital to compare yourself to others in a performance of measures that they think are high risk for coding, billing, admission status, medical necessity, right? So we haven't had a PEPR for 2 years. So if you're part of your UR committee and you're used to looking at it, you haven't had to do it. It finally came back, right? They're having some bumps in getting it rolled out, getting hospitals to figure out who gets the PEPR, but it's coming, right? If you're a major medical institution, for example, Mass General, big institution, it's probably like your CEO or your CFO that got the email, which they probably quickly deleted because they thought PEPR, that must be spam. But so for now, they're the only ones that can access it. Starting in spring, they're going to open access to your quality people. So you may have to wait. If you're not familiar with PEPR, it's an Excel workbook that comes, right? And it's got all the tabs along the bottom for all of the measures, right? This is the list of measures that they have on the PEPR, right? So if you just glance through some of these, you can see that there may be risks of documentation problems, coding problems, right? Septicemia, how many medical and surgical admissions have CC or MCCs? Who's getting spinal fusions? How many people go to nursing homes after staying 3 days? What's your readmission rate? Your short stays, right? Your diagnosis of malnutrition. So they picked out topics that are pretty pertinent to today's hospital care. The PEPR has tons of data. If you go into a measure, you can see, every measure has a table like this, just full of numbers. But luckily, they also provided us with pictures, right? So if you're looking at your PEPR, in this example, this is the hospital's percentage of admissions, their medical DRGs that have a CC or MCC on the claim, right? As you probably know, if you have a CC or MCC, you get paid a higher rate. So Medicare says, gosh, our hospital's making up CCs or MCCs just to get more money. Well, in this case, on the far right, this hospital's performance is above that solid red line, which is the national 80th percentile. So they're relatively high, right? Now, they may want to say to themselves, gosh, are our patients all sick enough that we would be in the top 20% nationally for sickness of patients to justify our CCs or MCCs? And maybe they say, yeah, we're a major medical institution. We have lots of sick people. It makes sense, right? Small community hospital that transfers out a lot of stuff may say, gosh, we better take a look at this. Let's make sure when a doctor documents a CC or MCC that it's justified. Again, that may fall to your CDI department, but just to be aware what's going on, right? They also, I mentioned report readmissions. I'm critical of them, and CMS has heard from me because if you look at the graph of this, you can see the 80th percentile rate is somewhere around 3%, right? So if you're going to show this graphically, why would they make the bar graph go from 0 to 100%, right? This hospital has no way where they really fall, right? So formatting is not their forte with this PEPR. I mentioned, again, they made some changes. The only real change they made to their listing was removing excisional debridement, right? They spent 2 years to decide to remove excisional debridement. That's pretty pitiful, honestly, right? I know many people that I knew wrote to them and said, one of the measures is total knee replacement. It's not inpatient only. We know it's a risk, but hip replacement is the same. right? It's almost the same surgery. It's basically the same surgeons, the same kind of care. Why can't you add hip replacement to knee replacement so we can look at all of our joint replacements together? And for whatever reason, they said, nah, we're not going to do that, right? Again, does that make sense? It really doesn't. All right. So I mentioned earlier prior authorization programs, right? They are optional, right? The new WISER program that is an optional program, right? Where you don't have to get prior authorization, but if you don't get prior auth, you won't get paid until you submit your records and they run medical necessity criteria. So if you're part of that program by now, you should have it figured out. All right. Um, there's also an ASC prior authorization program. So they're starting to expand into the surgery centers to get them to make sure, again, that stuff is not moving out of the hospital into the surgery centers to avoid being scrutinized for medical necessity. All right. So I mentioned the WISER program. Here's the states that it's affecting, right? They randomly picked 6 states. I mentioned the using AI companies to do it, right? It's a simple workflow, right? We're not going to go through all this. That's a whole lecture by itself. But basically the provider sends their records, uploads them via portal, faxes them. You can mail them by U.S. Postal Service. The WISER company with AI reviews it and says yes or no. And if they say yes or no, if they say yes, obviously you go ahead. If they say no, you can resubmit more information. You could supplement with more documentation. You also have the option to just go ahead and do it, right? And then even though you think it was denied, if you think it was medically necessary, you can perform it. You'll get a post-payment review, and maybe you can convince them to authorize it. Right. There's a whole list of topics. Again, many things that they think are at risk for being performed for non-medically necessary reasons. Right. On the second from the bottom is the skin substitute use for non-healing wounds. That's a big topic of conversation everywhere. Right. The pricing of those skin substitutes, the growth in the number of skin substitutes. So this will be an area that's very interesting to watch if you have a wound care center or you have physicians who do these things. Um, it's going to be interesting. Vertebroplasty is on the list, epidural steroid injections, which are quite common, implantation of a bunch of devices at the top, lots of stimulators. All right. So again, as case managers, as UR staff, making sure that medical necessity is well documented is going to be crucial. One point I want to mention as part of WISER is that if the AI system says, no, we're not approving it, the WISER company must send it to a human, right? The human has to review it to see before they issue a final negative determination, right? So I think it's funny that actually Medicare used the word to have a human clinician. I think I can't picture a non-human clinician, but it just brings up the point that it has to be a actual practitioner. The other important thing to note about this, by the way, is that the practitioner must have expertise in the area in order to deny the authorization. So if you're part, again, asking the question, doctor, what is your specialty? Have you done this procedure? If they haven't, they should not be making these determinations. If I have to say there's a good part of this program, is that if the hospital gets denied, the doctors get denied, right? So the surgeons, the anesthesiologist, the radiologist, everybody else that had submitted a claim as part of that hospital stay gets denied. We've always been asking for physicians to have skin in the game. Here's the time to see it happen. So again, always best to avoid it. Let's get them all the information up front. When patients are scheduled for surgery, get the physician's office notes into your hospital record, have it part of the medical record. So when it's reviewed, it's all there. Speaking of prior authorization, Medicare Advantage plans, right, often require prior authorizations. They also are allowing peer-to-peer calls in general when they don't want to approve something, but they're starting to cut back on their peer-to-peer calls. right? They're starting to say, no, we're not going to allow them anymore, right? We're just going to deny, and then you have to appeal. It's become a big bone of contention in the UR world, right? A lot of people are upset saying they have to offer peer-to-peer calls. By regulation, they don't, right? They're really offering it, to try and avoid a denial, right? When they issue a denial, it's a lot of work on their side, right? So it's often a contractual issue. If you're getting payers that are refusing to do peer-to-peer calls, go to your finance team and saying, hey, those peer-to-peer calls helped us avoid denials and all that rework. Let's see if we can work with the plans to allow us to continue to do the peer-to-peer calls, right? Um, one of the ways that hospitals often fought back about MA plans denying things inappropriately was to file complaints with CMS, right? Because when Medicare Advantage plans got enough complaints, they actually got a lower payment in their bonus at the end of the year, right? But Medicare is taking the number of complaints out of the STAR program, which determines their bonus. So we're losing that leverage, right? But we still should do it. CMS should still be aware, right, that they are creating hurdles. That if you have a patient who met the 2 midnight rule, who was inpatient only, right, who had a long stay, and the MA plan is not approving it, complain, right? Follow the process and file a complaint, right? If it's a patient-related issue, an MA plan is not approving inpatient rehab, they're not approving SNF, right? In that case, the most effective thing you can do is get the patient to complain, right? So you have a patient in the hospital who had a stroke, and your doctors think that they require inpatient rehab, and they meet the Medicare criteria, right? You absolutely should fight for them, right? You should, but get the family on the phone to the plan saying, why aren't you approving inpatient rehab for our family, our loved one? Right? They meet the Medicare criteria. This is their best chance for success. If you don't approve this, we are going to call 1-800-Medicare and we're going to complain, right? That often has a lot of weight with MA plans, right? Again, when you're trying to get it done, MA plans think it's just about money. When it's the patient, it actually works. I do put on here to ensure your complaint is legitimate and that the request meets CMS criteria for coverage. I have to say, and some of you probably will nod yes, that oftentimes when a patient's hospitalized and you call for a PT consult, the PT referral says recommend SNF. And then when you go and you look at the patient and you look at their needs, they often truly don't have skilled nursing facility needs, right? They may benefit from it, right? But they can receive the care they need at home. They can get outpatient therapy. They have a driver, or someone to take them, all those other things. So we have to be careful that we're not complaining about things where the criteria truly weren't met, right? By the way, speaking of the physical therapy issue, I do like to say, tell your physical therapist when we call them that please evaluate the patient. Absolutely, in your mind, come up with a recommendation, but talk to case management before you say anything to the patient or you document something, right? If the patient doesn't have coverage for SNF, right? And the physical therapist tells them, I think you should go to a nursing home. And then you go in and say, gosh, just so you know, you don't have coverage for a nursing home. It's going to cost you $4,000 to go. They're going to be upset at you, right? Not your fault. The therapist set that expectation, right? And you have to be realistic with them. So work with your therapy teams on that so they understand that patients have different benefits, right? You may also find they have a nursing home benefit, but they're in an insurance plan. And honestly, the nursing homes that are contracted are probably not ones you'd want to go to, right? You looked at the star, the CMS Compare site, and they've got 1 stars and they've had lots of complaints about, poor care and their staffing isn't great. And maybe it's, explaining that to the patient before setting the expectation that they're going to be able to go to that 5-star nursing home and someone else is going to pay for it. All right. So moving on. The other thing you're probably hearing about is what Aetna has done in the utilization management world. And as we know, again, the MA plans have to follow the 2 midnight rule, right? They have to approve inpatient admission for patients who fit that expectation of 2 midnights or the case-by-case exception, et cetera. What they did, they got some sneaky lawyer to realize, well, wait a minute, let's just approve everybody as inpatient, right? So we meet the regulation, but we're just going to pay some inpatient stays at a lower payment rate. And they said, if you stay as 2 midnights to 4 midnights, we're going to review MCG inpatient criteria. And if the patient meets inpatient criteria, then we'll pay you for the inpatient rate. But if it doesn't meet MCG inpatient criteria, we're going to pay the hospital your observation contracted rate. Right? So it makes it's legally appropriate to do that because the patient maintains their inpatient rights, right? The patient's an inpatient, they get their important message from Medicare, they get their right to appeal. This is purely a payment issue, right? So if you call for inpatient, you ask for it, they're going to give it to you. But they're going to run MCG on the backside and it'll determine how much you get paid. All right. So the first thing to say about this is not your fight to fight. This is finance's fight to fight because they agreed to a contract that lets Aetna do this, right? It's a payment issue. You got the patient in the right status, right? Nonetheless, they're going to come back to you and say, okay, case management, you guys have to figure out how do we get them to meet MCG inpatient criteria. And luckily, there's a way to do that. Because if you look at MCG's supplemental criteria, they actually state clearly that if they've received medically necessary care that meets the 2 midnight benchmark, they require inpatient admission. So they meet inpatient criteria under MCG if they stay more than 2 midnights. So Aetna is kind of, I mean, they're going to play games with this. They're going to say, no, we weren't talking about this part of the MCG. We were talking about they have to have the blood pressure of this, or they have to have a sodium level of this. But if they're going to take MCG criteria, and MCG is absolutely right to say this about Medicare, right? So watch out for this, right? Again, it's not your fight to fight. But what we can do is, again, making sure on day 2 and day 3 and day 4, the documentation does support the need for ongoing hospital care. Right? So if you figure out how to get your doctors to document better, please tell me, because everybody around the country wants to know how do we get it. Speaking of that documentation, here's a chart from a patient whose chief complaint was weakness of their left leg, and they're 85 years old. Right? So this is what their family history looked like. It was reviewed. Their review system said all reviewed negative except as HPI. And their physical exam, you can see, had lots of stuff in it. Now, why do I show this to you? Starting in 2023, or is it 2024 now? It's hard to keep track. 2024, January 2024, hospitalized patients, right? So the physicians seeing hospitalized patients determine their visit level, right? So when the physician sees the patient in the ED, in the hospital, the visit level, what they code and they bill for, no longer depends on them having a family history, a full review of systems, a full physical exam. The code they choose is based on their medical decision making that they document or the total time they spend with the patient. In the past, they did have to have a full review of systems, a family history, a complete physical exam to get paid for the highest level admission visit. It's gone now. They only need to document what's pertinent. The family history in an 85-year-old is not pertinent, right? The physical examination in a patient with leg weakness, some of these things, the examination of their back, right? Their eyes, their pupil their conjunctiva, their sclera color. All these things are not necessarily pertinent, and they don't need to document that, right? Because they're counting on this to get the high level visit, but it doesn't count, right? So my message to you guys, actually, because I'm rambling a little bit, it is early, by the way. I'm in the Chicago area, so I'm an hour behind you. So I'm actually wearing my pajama bottoms. I told June I wouldn't wear my bathrobe. I was tempted, but I do have pajama bottoms on. Um, so if you see this happening, go to your physician advisor, go to your medical staff leadership and say, can we teach our doctors about the new documentation rules, right? Instead of putting in all this superfluous stuff, if they spend that extra 2 minutes documenting their assessment and plan, it's going to help everybody. We can understand what they're worried about, what they're planning to do, how long it's going to take, right? We can all provide better care if they didn't do all this extraneous stuff that they don't need to do and document the good stuff. All right. Okay, next thing. Here's Mrs. X is a healthy 35-year-old female, came to the doctor with cough and low-grade fever, no dyspnea, no high risk factors, negative medical history, exams are normal, pulse ox is 97, she has some crackles on the right, right? Chest x-ray, small right lower lobe infiltrate. So this is a patient going to their doctor, right? Maybe it's one of you. I'm sure all of you have gone to the doctor. What do you think the doctor's going to prescribe for that patient, right? If someone, just think to yourself, is it going to be A, B, or C, right? And I bet the majority of you said A, right? That they're going to get 7 days of an antibiotic. Have you ever thought to yourself, why do we prescribe 7 days of an antibiotic? Well, I'll tell you why. Because in the year 321, Constantine the Great decided that a week was going to have 7 days, right? There is absolutely no scientific data supporting 7 days of an antibiotic compared to 6 or 8 or 5, right? Why do we order refills for prescriptions for 30 days? Why not 31 when there's more months with 31? Why not 28? Why not 29, right? Because 30 is a nice round number, right? If you write for 31 days, the pharmacist is going to roll their eyes and say, what's wrong with that doctor, right? When we give medications, right? I'm sure some of you have to take a medication. You take it once a day, right? Is it actually possible that every single pill that we take has a 24-hour response curve, right? Is it possible? Absolutely not, right? Some pills after 18 hours, maybe it's 26 hours, 27. It's not, right? It's impossible. We give 24-hour pills. Why? Do we prescribe 5 days or 7 days? Because it's dogma, right? Dogmatic practices are everywhere in medicine today, right? We do things not because it's scientific, because it's just the way things have been done and carried on. And sometimes we do need to stop and look and say, things we do dogmatically, do they make sense? Right? We all much rather have that little pragmatic puppy than that dogmatic bulldog, right? And think about medicine, right? There's lots of things happening in medicine that are dogmatic, that don't have science behind them, right? NPO after midnight for surgery. You will hear many hospitals are now realizing that is just dogma and there's no science behind it, right? And they're letting people take liquids before surgery, right? In fact, there's orthopedic programs where they take some high, I don't know if it's carbohydrate drink the morning before they come to the hospital, and it improves outcomes, right? For years, as a physician practicing in the hospital, when we got calls, and I'm sure some of you nurses will be saying yes, we got calls for patients in the hospital whose blood pressure was high from the nurse, right? Oh, Mrs. Smith's blood pressure is 160 over 80. What should we do? Oh, give her Procardia sublingual 10 milligrams. And the nurse would walk in with that little capsule, puncture it, and drip it under their tongue, right? Because that's what we did. Elevated blood pressure, got to treat it. Turns out we were causing harm, right? So all of these things listed here, right, are things that were dogmatic. We believed them without realizing whether there was any science behind it, right? So it's interesting that things change, right? I started hormone replacement at menopause because everybody got hormone replacement, then nobody got hormone replacement. And now we're going back and saying maybe we really should look at the science and figure out who can receive hormone replacement, who should receive it, etc. So, why am I talking about this? I'm talking about it because I think it's important for all of us to continue to learn in our care of our patients, right? Ask questions, right? Empower your staff to ask questions, right? I found some of the best resources in my work as a physician advisor was talking to the nurses and being a resource for them when they didn't understand why the doctor was doing a test to this patient in the hospital, right? They didn't want to challenge the doctor, but they could ask me, right? Why are we doing a colonoscopy on this patient who's in the hospital for cellulitis? Well, turns out it was just doing done because it was a convenient time for them to do it, right? So, again, keep learning, read your nursing journals, whatever your social work journals to know what's happening and keep up with medicine, right? And sometimes it says in the bottom, don't just do something, stand there, right? Maybe we shouldn't be doing things that we're doing because maybe the best thing to do is not do it. All right, that's my philosophical thing. Quick, last slide, then we get to questions. All right, just so you know, every year Medicare does look at revamping their quality measures. The quality measures go into our star ratings. They're used by US News and World Report, um, the Care Compare sites, all of these external agencies, leapfrog, that are looking at our care and publicizing these things. And it also, of course, affects how you get paid. Because if you don't perform on quality measures, the hospital gets dinged, right? So, what are they considering for adding? Advanced care planning discussion or having that document in the medical record for hospitalized patients, right? For all patients, it may be a requirement, right? The simple patient coming in, will they say, someone's coming in for a colonoscopy? Outpatient, we need to have, again, advanced care planning done. We don't know. We're going to have to wait and see. Shared decision making for outpatient surgery, right? There is required shared decision making for certain procedures for Medicare, like the Watchman, right? So they may want to make sure that there's documentation for patients coming in for outpatient surgery, that the doctor offered them alternatives, the choice to make a decision, right? What the risks and the benefits are. Excess days after hospitalization. So patients who leave the hospital, right now we look at readmissions, but they're going to start tracking potentially patients who come back for care after being in the ED and sent home, after an OB stay, and after inpatient stay. Again, not just readmission, but returning to the ED, getting rehospitalized, your hospital, other hospitals, etc. Right? So it's going to be more thorough monitoring of patients who returned for care. Again, stressing to make sure that when the patients leave the hospital, they're optimally prepared to not have to return for care. We know they measure readmissions, part of the readmission reduction program. They're thinking about adding sepsis. And a scary one is the bottom one is ED timeliness. All right. I'm sure many of your hospitals, are ED boarding patients, right? They are going to be measuring boarding in the ED for greater than 4 hours, right? And ED total time of greater than 8 hours. These measures, this one scares me, right? Why does it scare me? Because I'm sure many of you are already faced by patients who get sent upstairs who potentially could have gone home from the ED if they just provided a little more care. Another nebulizer, another dose of antibiotics, and maybe they could have been discharged. But now we're going to have these measures where, gosh, we got to get them out of the ED. Can't, we got to disposition them, right? Got to get them upstairs, right? How they're going to do it when hospitals are full and there's no place to put people, will an ED hallway count as ED time? Can be hard to see what happens with that. But expect low pressure there on your, case managers to get people in and get people out and shorten your length of stay, etc. Speaking of length of stay, by the way, the other program I didn't talk about because it doesn't affect, I think any of the hospitals I thought were involved is the team, the episode program where Medicare is going to again look at bundled payments. So they're going to pay hospitals for certain surgeries based on the surgery and then all care for 30 days, right? So patient has their joint replacement, they go to a nursing home, they stay in a nursing home for 20 days, they get home. They have a total of 30 days of care. All those costs are going to be compared to a baseline set target rate. And if you spend less, the hospital gets money back, right? Now, why am I talking about this? Why did I go off on this deviation? Because this is a case management thing to be aware of. With these bundled payment programs that are looking at total cost of care for 30 days, think about if you send your patient, get them out quick and send them to a nursing home, right? You now have a nursing home cost that 20 days of care as part of your bundled cost compared to if you kept them in the hospital for another 2 days and were able to discharge them home. Maybe you could have kept your total cost of care significantly lower, right? Because you didn't send them to a nursing home where sadly they're going to probably be there for 2 weeks, 3 weeks, right? So when you're getting measured by length of stay, you can now say, wait, our length of stay is longer because we're keeping the total cost of care down, right? We're going to have to start thinking globally about those measures instead of just that one patient getting them out as quick as they can. All right, so I talked a lot. That's my email address. You can email me if you want. Some of you may be aware I have a website, ronaldhirsch.com, if you're interested in utilization management stuff, if you're looking for the inpatient only list, if you're looking for little cute YouTube videos to teach your doctors about stuff. My website, I don't make any money off of it. There are no ads. Take a look. It's good stuff to have good reference. All right. So, June, are you doing questions?
I am. Thank you, Dr. Hirsch. That was excellent. I always learn something new. I think we all learned more than one thing. It was tons of great information. Thank you so much. So there's one question in the Q&A. So
Mm,
really, if anybody else wants to add something, we can do that because we have a little bit of
sure.
extra time. This one is, so if the 87-year-old lives home alone, has
Yeah.
no family, therefore will that patient need
Uh,
a sniff?
okay. So I think I know what Michelle is getting at here. And let me start by saying that the three admit for sniff, as I talked about, is
Mhm.
really for the surgical patient where we're doing something to require them to need rehabilitation, right? So it's specific to surgery patients. This is not bringing grandma to the ED. We can't take care of her anymore. Can we admit her because she needs to be placed somewhere? All right. So, but a knee replacement, right? They're having a vaginal hysterectomy, any of these non-inpatient only surgeries. If there's a valid reason for them to go to a nursing home for rehabilitation, yes, you make them an inpatient. All right. Now, Michelle's saying to herself, but the day after surgery, they're doing fine. They could go right to the nursing home. And the answer is yes, they could as self-pay. Medicare requires 3 inpatient days. So what you do is you keep them as inpatient. You tell your physical therapist, this patient, you need to work as hard as you can so we can try and get them home. Right. And maybe after 3 days of inpatient therapy, they can go home and they won't need that sniff. So the daily notes should not say waiting for sniff placement. They should say continue aggressive physical therapy in hospital, right? So I hope that makes sense. Would all of us love to be able to admit grandma to get her placed in a nursing home and have Medicare pay for it? Sure, but that's not available, right? That's where their supplemental, that's where Medicaid, et cetera, comes in, right? I'm really
That
scared.
an-
Oh, go ahead.
I was gonna say, so that answer includes knee replacement because Michelle added that.
Yes. Yeah. Knee, hip replacement. Again, now all the orthopedic procedures are coming off, spine fusions, anything where, again, the patient will not be safe to go home and rehabilitate by themselves. All right. So, again, and let me tell you the other case management part of this is this shows you the crucial role you can have in pre-op planning for surgeries, right? How many of you have gotten the call Friday at 4 o'clock for the patient who needs to go to a nursing home and it was an outpatient surgery, right? You should be there in scheduling, seeing who's being scheduled for surgery. What status should it be? Do they have comorbidities? Do they need a nursing home? What are their plans? So you can start making these arrangements before the patient shows up, right? Again, talking to the orthopedist office saying, hey, when you're seeing your knee replacement patients pre-op, if you got someone you think might need a nursing home, call us ahead of time. Let us help you guide you through the process. Right?
So I think you read Michelle's mind because
Yeah,
she's put in there. Yes, I was asking surgery calling me every day.
that's great. And be sure to thank them for calling you if it's pre-op. If it's post-op, tell them, why the heck didn't you call me ahead of time?
There you go, Michelle. Cool.
This,
So
yes, and I do see the Q&A, June, and I do see Angela's right. The team model
yes,
does have that SNF waiver only for those surgeries, right, that are part of the program. But again, don't jump on the SNF waiver, right? Think about your overall 30-day cost of care and talk to your administrators about extending the length of stay a day or two if it might help you get the patient home with home care or outpatient PT, right? Maybe,
mhm,
again, a lot of them may need a sniff. You bypass surgery, it's a major thing. They can't go home after another extra day in the hospital, but maybe there are patients where it will be possible.
yeah, that's a great question from Angela. So I know Angela really well, and she's actually um, the um, the collaborator for her network for waivers.
Oh,
She's the
great.
expert in that.
Oh,
So that's a great question. Okay, I had one. Let me just see if there's an, oh yeah, there is another one. Let me just go to that. Excuse me 1 minute. Get down. There we go. Oh, I think it was a thank you. All right, so my question is for the pepper, since it's coming back or it's back, um, do you recommend that we as case managers bring it to the utilization management meeting that is mandatory for conditions of participation?
absolutely. Well, first of all, the first question is who's responsible for interpreting the pepper? And the pepper has really should probably honestly go to compliance because there's many areas that are outside the UR realm, right? Again, is CDI part of your program? Part of the UR case management division? Probably in a lot of places it's
Yeah,
not. So why should you be doing CDI interpretation stuff? But I think the UR committee is in the perfect position to address many of those issues and understand what needs to be done and who should be doing it. So yes. Again, it does take someone who's skilled in interpreting it. You just don't want to bring it as an agenda item and, throw this Excel spreadsheet at a bunch of doctors who don't know what they're looking at. Someone needs to come and explain what they do. I do that for many hospitals around the country where they send me the pepper. The pepper, by the way, has no protected health information, so you can share it, without a business associate agreement. Um, so you can find a pepper expert to kind of help you interpret it and take back messages.
that's excellent. Thank you, Dr. Hirsch. So, do you have an answer? This might be a tough kind of question, but if we look at everything that's brand new that we have to respond to from the government in 2026, And when we look at each one of the initiatives, I sort of imagine them like it's like a set of dominoes. And so you come up with an intervention for one, and then it kind of hits the next domino. And there's like, so do you have any overall recommendations for us? Like to, because our heads are spinning with all of the initiatives that we have and all the change in regulations.
It you um Yeah, I think keeping your head above water, just doing the daily tasks you have is hard enough, right? Adding on all this other stuff. Um, and I'm going to give a plug, June. I'm going to give a plug for rackmonitor.com. And
Yep.
there's also ICD-10monitor.com. So as June alluded to, there's a Monday morning, there's a podcast or webcast. You can listen live or you can listen on recorded. Um, and there's so for us it's Monitor Monday, and on Tuesday it's Talk 10 Tuesday. I know there's many segments that are just kind of that little blurb of what's coming up and what to be aware of, just to raise your awareness. They also publish Talk 10 Tuesday or ICD-10 Monitor on Tuesday publishes 3 or 4 articles, and Rack Monitor on Thursday publishes 3 or 4 articles that have some of these pertinent issues. Listen in. If you hear something interesting, figure out who in your institution should be addressing it. Don't take it on yourself, right? That's the most important thing. When they ask for volunteers, make sure you take a step back and leave somebody else ahead so that they get appointed to do the job. Um, the other thing is, some of you may be aware of Becker's Healthcare. Becker's publishes online. They have emails every day on a bunch of different specialties for hospitals and surgery centers. It's a nice way to just kind of glance at the headlines and see if something sticks out as pertinent to your daily work. All right.
Thank you, Dr. Hirsch. More good advice. And I just want to add to, of course, CMSNE, because we're striving with conferences to keep everybody informed all the time.
Yeah,
So
absolutely.
another really excellent presentation, Dr. Hirsch, and it's 9:44. So as always,
Oh,
you're always perfect and on time. Here comes the thank yous to you. Really, we
thank
so
you.
appreciate
All
you
right. And I'll
at
hope to see
CMS.
you guys. I want to see all of you at CMSA National. I'll be there. I'm speaking. So come and say hi to me.
Great. I'll be there. Sure. All of us.
I'm
Let's
sorry, June.
join and go see Dr. Hirsch there in Las
There's one more
Vegas.
question on the bottom, June. I'm sorry.
Oh,
That
I'm
was
sorry. I'm sorry because my screen isn't rolling down. Don't leave yet, Dr. Hirsch. What's the
Okay.
biggest anticipated hurdle you foresee for teaching hospitals with all these CMS changes? Kind of the same, but so they wanted
Well,
one answer. Biggest
yeah.
challenge.
And I'm running over time. Actually, it's something I didn't even talk
No, you're
about.
not over time. You got
Oh,
1 minute.
okay.
I'm
The,
counting.
the there's something called site neutral payment policies. And site neutral payment policies is a big push that why should hospitals get paid more than surgery centers for doing the same surgery?
Mm,
There's a push to kind of normalize payments. And what the result of that is going to be that hospitals are going to be paid a lot less money for major surgeries. That's going to influence, obviously, financial stability of hospitals, right? To be able to support teaching programs, right? So Google site neutral payment policies to read about that so you understand the potential risk that that may pose to hospitals of all kinds, right?
yeah. Well,
Yeah.
great answer and
Okay.
great last question. So thank you so much, Dr. Hirsch. Are you sticking around?
I'm be around for a little bit.
Dr.
Okay.
Hirsch.
Stay warm. And here's Jean. Turning
Hi,
over to
Dr. Hirsch.
her.
It's Jean O'Leary. I just wanted to ask you the stupidest question on record. When we went to update our copy of the important message, we noted that the form that was on the website was out of date.
Yeah, yes. So the IMM, the Moon, and the detailed notice of discharge are out of date.
All out of date.
Medicare is aware of it. Continue to use the old one. Medicare will post the new one.
Great.
And whenever they get around to getting it approved, and you'll have 60 days to transition.
Okay.
So
That's very
I will be
helpful.
mentioning that on rackmonitor.com when the new ones come out.
Oh, great. Thanks. And also there was a comment from Ann Walker from Vantage Healthcare that the American Association of Post-Acute Nurses has a nice at a glance tool that breaks down VBC, QRP, and QM.
Oh,
It's in the
great. And
chat.
maybe I can
Um,
understand it. I avoid those things.
You do?
There's so many programs, it's so hard to keep track. It really is.
Right. So it's
Yeah.
in the chat and it's the American Association of Post-Acute Nurses.org. And thank you, Ann, for bringing that up. Okay, Dr. Hirsch, pleasure, always.
Thank-
We're going to turn over to our own Vanna White, and we're going to pull the names for the early bird persons. And I just wanted to say that as a person planning a conference, when 45 people sign up before we even hit the month that it's in, it's a real vote of confidence. So we thank you for that. And with that, I will hit the first spin. All the 45 people that registered before January 3rd are on this. Okay, Barbara Collishaw, are you here? Let me pull in. We got a clap over here. Barbara, are you with us? Well, let's give Barbara a chance to come down off the ceiling from winning. And let me roll another one.
She raised her hand.
Great, thanks, Maureen. Number 2, for the many faces of case management, the blog. Michelle Quimby. Here's number 2. Michelle, gonna give you a minute. Oh, people celebrating these winnings. Michelle, are you with us?
Really, she's here. She asked all the questions, 3 of them.
Okay,
Oh,
here.
wow.
She's
Let me
good.
wake up. Okay, let's go with number 3. Here we go. Janet Hill Heavey. Great. Janet, are you with us? I'm sure she is. You never missed a conference. I know Janet from many years ago. Well, thank you, everybody that signed up as early birds and before January 3rd and signed up for the 2 days. We really appreciate it. And at this point, I'm going to turn it back to Maureen.
Okay, I will mail those books out to you people when the snow is gone, probably midweek. So watch for that in the mail. And
Great.
we are going to break, and we will come back at 9:55, I believe it is. Unless my
Like 5 minutes.
yeah, in 5 minutes. So we will see you then. Take a
Thank
quick
you.
break, get a cup of coffee.
Thanks, Maureen.
Yep. I took the annoying music off.
That's too bad. It sounded like it could have been good.
Genia audio and video is still on. Mary, we're ready when you are.
Okay. Welcome back, everybody. We're going to continue on with the conference agenda, hearing from our next two sponsors. So first, we'll hear from Genesis, I think a well-known post-acute support for us. So Maureen, if you want to go ahead with that video.
Good care is trying to do the right thing and waking up every morning to show. We take care of people. We take care of the community. Regardless of opinion, we give our whole life to that. Because I think it's something to be proud of.
I have been in this facility for almost 18 years. I feel like this is my second family.
It's just a whole different atmosphere. It's just that upper level of care all the way around.
The staff knows us, and that means a whole lot. That when I come in, they say, "Hey, Amy, what's going on?" It's nice to know who is taking care of your people. They seem to really want to make people feel like they're welcome here.
They can trust us to take care of their mother, their father, their grandmother. And when we see them at the grocery store, when we see them at the movies, when we see them at the gas station, we want to have great relationships with them in the facility and outside of it. Community matters in such a thing.
My father too. He likes the food, the breakfast here. Breakfast is always his main meal. I might not see him 2 or 3 days. I come in for, well, I had a good breakfast this morning. And he's kind of a picky guy. 90% of what he had, he likes.
We're not here for profit. I'm here to provide good food and quality to the best of my abilities with what I'm given. This is their livelihood. This is their home, and we have to treat them as if it's their home and they're our family. We see these residents every single day. When my dad first had his stroke, I reached out to everyone, and everyone but here, their first question was, what kind of insurance does he have? Here, their first question was, I'm really sorry what happened to your dad. Tell me a little bit about that situation. Here, it's more about the patient.
The culture here is unlike anything that I've experienced, even in other facilities. The teamwork is unmatched. They're all, I can honestly say, they're like one of my best friends.
We take care of our staff just as much as we do our patients. It is just a joy to be able to see people grow, just to see the investment that Genesis allows us to invest in our staff, to allow people to better themselves. Just I don't want to be a part of anything else.
Good care is trying to do the right thing.
Why did it?
Okay.
Okay,
And waking up every.
I'm trying to get out of this. Sorry. Let me go to the next one. I'm sorry, everyone.
It's all right. Gotta love technology.
Oh, gosh.
Good care is.
I sometimes feel like I'm really smart, and then other times I don't. There we go.
Okay, excellent. So thank you to Genesis for that summary. And now we are going to hear from Ann Walker, who is the head of network development with Vantage Healthcare. Thanks for being here, Ann.
Thank you. Good morning, everyone. I've been fortunate to be with a couple of organizations over the years who are willing to and happy to support the work of the Case Management Society. So I'm happy to be here again talking to you about some resources in the post-acute world out there. And I'm now working for Vantage Healthcare, and we provide medical services for SNFs and assisted livings. Next slide, please. So this gives you a little snapshot. We cover all of the New England states. most of which in Massachusetts, but quite a lot, as you can see, in southern New Hampshire and Maine. And we are growing in Rhode Island and Vermont as well. So our practice is led by Dr. Vishal Kuchkula. Some of you may have known him over the years. He's been very active in Eastern Mass in the post-acute world. And our model is we provide medical directors and advanced care practitioners on site. So they take care of those short-term rehab patients and also the long-term care, primary care in nursing home units and also in assisted living communities. And our providers don't just come and go. They get integrated with the teams on site and become part of the team with our SNF and ALF partners. We have over 100 physicians and PAs, and we have about 100 SNF partners and about 115 assisted living partners across New England. Next slide, please. In addition to that core model, we also have a number of enhanced services that we bring to our partners as they need them, including hospitalization prevention programs. Dr. Hirsch certainly spoke to the ongoing importance of that for all of our work. We have a behavioral health team that can support. We have specialty medicine, such as cardiology, endocrinology, that we can bring to a site independent of the primary model. We have chronic care management program, which you're probably hearing a lot about these days under CMS. And so we have a team of chronic care managers that support our long-term care, primary care patients. We participate in the guide model. This is something new for us, so we're just getting that off the ground. We have a really strong telehealth on-call service, great response times, 2 to 3 minutes, and a 94% treat in place. So great data. And I've heard from a lot of SNF providers in the region who are not even in our network that are using the same telehealth on-call service with the same great results. We participate in a long-term care ACO to help give extra support to those more frail, elderly, more complex patients. It sort of works in tandem with the Medicare ACO you might be familiar with by increasing sort of that price, if you will, per patient over the course of the year, knowing that our seniors are more vulnerable, they're more medically vulnerable, and they need more care than the rest. So we're happy to be part of that. And we have a strong commitment to value-based care. In my role at Vantage, I'm learning everything I can about value-based care in the region, but in particular, the team model that Dr. Hirsch also referenced. And I'm doing everything I can to understand the priorities and standards from our hospital partners to help support our team within the SNF and the SNF to really be the best that we can to collaborate and partner with you as you're transitioning your patients that are appropriate for a SNF level of care. We integrate with the electronic health records on all of our sites, and we also have a resident and family portal for our primary care patients. Next slide, please. So if you have any pain points in your SNF and assisted living care out there that you're aware of, you see any gaps in coverage or services that we provide, please reach out. We're here to listen to what your needs are and see if Vantage can bring some solutions to the table for you. And I appreciate everyone's time today, and nice to see all of you. And thank you to the Case Management Society.
Thank you, Anne. We really appreciate you being here and reviewing that really dynamic program. That's fabulous. And thanks to Genesis as well. So now I will hand it back over to June Stark to introduce our next speaker.
Thank you very much. Thank you, Ann Walker, and all our sponsors today. And thank you, Mary McNulty. Our next lecture is entitled The Management of Complex Patients Across the Continuum. I want to remind you all to please put your Q&A in that box rather than the chat. We have 3 speakers for this session, all experts in the field of transferring patients and dealing with complex care issues. The first one is Kim Berry, who's the Vice President of MGB Care Continuum, Trancy Escobar, who is MGB Case Management Executive Director of Complex Care and the Care Continuum, and then Mary Ann Vieno, who is the Director of Clinical Operations Population Health Services. To save on time, each one of these speakers will also do a brief bio of themselves. So without any further ado, I'm going to turn over to Kim. Kim, welcome.
Hi, thank you, June. Thank you, everybody. It's nice to see some familiar faces in January 2026. Time definitely flies by. So I'm going to go ahead and share my presentation with you. And hopefully you can see that on your side. And I can, perfect. And I can put this in presentation mode and just jump right in. So thank you for having us today. Today I was hoping to review some of the changes and evolutions and improvements that we've made across Mass General Brigham. So Mass General Brigham is the system, formerly known as Partners, that's inclusive of 11 different medical hospitals, the Spalding Network, MGB Home Care, numerous ambulatory and surgical centers across the region. It's a very large system, and what we're and the adventure that we are undergoing is continuous integration, continuous improvements, and continuous wraparound services for our MGB patients across the care continuum. So I'm with two of my colleagues today to talk about some of the more recent advancements across MGB. We have no conflicts of interest related to this presentation. So initially wanted to provide an overview of the MGB strategy, talk about how we're constructing the inpatient hospital teams of case management and social work, give a brief overview of our new transitional case management team, and discuss how our ambulatory care compass teams are evolving to help meet the needs of our more complex patients across the region. Our three objectives for the presentation: to outline the essential responsibilities of the inpatient case manager and social work team members, to describe outcomes of the post-acute transition collaboration with the skilled nursing facilities, and to describe our outcome goals for the Care Compass ambulatory model. So I'm going to go ahead and kick it off and talk briefly about how we are structuring the nurse case management and clinical social work teams at the acute medical hospitals for MGB. So that is inclusive of 10 different medical acute care hospitals across the region. Overall, what we want to do is to create this integrated, seamless system of care delivery for our more complex patients. So that is inclusive of operations and also our population health teams. Strong emphasis on collaboration and how we're handing off in between our operational team members in inpatient hospitals and ambulatory settings, how we're handing off between those transitions of care. We want to make sure that we're providing high quality care, patient-centered care that meets the individual patient's unique needs. And I could see on the call today, there's many participants that are frontline case managers, frontline social workers, and also leaders. And we understand on a day-to-day basis the volume of patients that we are touching, that we are working with, and also their families that are contributing to care. And it's so important that we understand those individual patient care needs and develop a plan that's inclusive of what those care needs are and the priorities that the patient determines. So that's a really hard challenge, I think, in the high-paced, intense environments in which we work. The goal is to achieve superb health outcomes to reduce cost, optimize reimbursement, ensure timeliness of the patient progression, so patients aren't stagnant where they are, that they're continuing to progress. And of course, we want to enhance patient experience and efficiencies. So how do we do that? What we've been building, or what we're evolving to, is a full continuum of care to really bridge those high-risk transition points and maximize quality, and to make sure we're making fiscally responsible decisions along the way. Across MGB, we're building these teams to help guide, coach patients and families along the continuum of care. So you'll hear today about our Care Compass team from Marianne. You'll hear today from Trancy about our transitional case management team, and how, again, we're trying to stay connected with these MGB patients across the continuum, no matter where they're physically receiving their care. So just a little overview of how we're currently structured in the acute medical hospitals at MGB. The social workers and nurse case managers are located in the emergency departments, in the PACUs, observation units, inpatient units. They cover procedural areas and also receive a lot of calls from external locations across MGB, asking the expertise of our team members as to certain situations that they are experiencing, but also are very collaborative partners with other departments like revenue cycle, like patient access, like CDI, all of those collaborative teams across our health system that really rely on the expertise of our clinical social workers and case managers. Throughout MGB over the last 2 years, we've really taken a significant amount of time and effort to define the roles of case managers, whether they're clinical social workers or registered nurses, and really looking at job descriptions and updating those job descriptions so that they're truly relative to what's the current state. It's amazing how many different job descriptions there are and unique roles across the MGB system, and really involving the frontline team members to design those future roles in ways that match the current reality of what's happening. Also, the skill sets that are required for new employees to come on board to make sure that they have what they need to be successful. So that's really important, and the associated compensation of those demanding roles. So we recently just rolled out a new clinical competency and structured compensation grid related to clinical social work, recognizing their extensive education experience and unique role within the multidisciplinary team. We are very reliant on them to engage with patients and families and understand the uniqueness of each individual patient, to begin some of the psychosocial assessments that may have to continue outside of the acute care hospital setting. We're really focused on also the RN case management role to make sure those competencies and expectations are realistic. We're really relying on the team of clinical social workers and RN case managers to work together to actively participate and lead multidisciplinary rounds on the units. We've realigned some of our daily assignments to focus on unit-based team participation, regionalization of patients, so that we can have very focused conversations, especially for those super complex patients that really need a expertise level that's really focused at the quaternary level. So that's been very important to us. We've noticed that that team approach has helped reduce inefficiencies, helped us reduce our length of stay, help improve patient satisfaction, and lead to significant quality improvement. Okay. Across our case management and social work departments, we also have numerous unique supporting roles dependent on the size and location of the acute hospitals. We have case management assistants, social work assistants, community health workers. We have educators, data analysts, administrative assistants, and project management support. As Dr. Hirsch mentioned earlier today, often case management and social work are deferred to help manage and understand some complex situations and operations that are currently occurring in the hospitals. And it's important that we have these supportive roles to help us manage that, to help us track data, to help us consolidate a proposal for improvement, to help us understand and suggest different operations that will help improve the situation using the expertise that we have regarding the healthcare delivery system and the reality of what's occurring on the unit. Across MGB, we're in the process of centralizing utilization management and working very closely with our revenue cycle team members. We have experts in social work and RN case management that oversee utilization management workflows throughout the system. It's really pulling them together, and that is an amazing group of colleagues in making significant advancements, working with our contracting teams to bring forward some of the patterns that we're seeing, many of which Dr. Hirsch mentioned this morning, and saying, this is the reality of what's occurring, presenting it to our contracting team, and they can bring it up at the contracting table. Very helpful in terms of some of those conversations. Also looking at how we are interacting with some of the insurance companies when it comes to approvals of post-acute services. And I think everyone on this call knows how challenging and frustrating that process can be. So we're working very closely with our contracting teams with that side, that angle as well. Maybe partnering with some of our post-acute team members as well, and definitely our MGB Spalding and MGB home care teams to say, this is what's happening, and working with our contracting team to address that with our insurers. So the individual case management and social work departments remain reporting up to local leaders at each of the entities, and we continue to have really good partnerships with legal, risk, spiritual care, capacity and flow leaders. I mentioned our financial and revenue cycle team members, therapy, many different departments and team members, not only on the inpatient units, but upwards through the leadership teams to really engage in comprehensive performance improvement at each of the local hospitals. Throughout all of these changes, performance improvement, and efforts, we continue to focus on the CMSA standards, definitely on patient advocacy. This is something that we really strive to understand the patient and what they need, so we can develop a very unique care plan, and that is inclusive of social drivers of health. This is becoming more and more of an evidence-based driven concern. We see many challenges with patients that have significant social drivers of health that are impeding their healing, that are impeding their progression of care, and working with our population health team members, as you'll hear about in a little bit, to design unique care plans that will help the patient and family to be successful in the management of their disease and overall well-being. So we really are relying on our clinical social workers, our nurse case managers, and other team members in the multidisciplinary team to help guide that plan of care. And as always, this is a wonderful quote from our CMSA Today newsletters that we received. Problem solving, very creative and prompt problem solving. It's absolutely amazing what these multidisciplinary team members can focus on and situations that they navigate through. It's absolutely amazing, and big kudos to the case managers and social workers who are on the call today. Just absolutely amazing work and what you do each and every day. We also focus, obviously, on facilitation, coordination, and collaboration using the CMSA standard M. We do this every day, and I think this is also where it's challenging for us sometimes to orient new staff, because those who have a lot of experience go through these algorithms in your head as to, what the patient may need, and you're already thinking about different services in the community that may be able to help, that you will be reaching out to see how they can help for this particular patient. And when we're onboarding new staff, this is tremendously overwhelming. So this is something that we are also very focused on across MGB, is how we're onboarding, educating new staff, but also keeping current staff very informed to what resources are available out in the community, the name changes, the acquisitions. It's a lot to manage. So across MGB, really putting forth a comprehensive portfolio of onboarding education, ongoing education, and leadership development. This is a big area for us right now, and we've made some great strides. There's intense demand for coordination and collaboration across the system. And as you'll hear in a little bit from my two colleagues, we're trying to make it as streamlined and as efficient as possible. So I'm going to turn it over right now to my colleague, Trancy Escobar, and she's going to be describing how we are building that pathway to the next level of care. Trancy?
Thanks, Kim. Again, thank you for having us. It's a pleasure to be able to communicate some of the work that we're doing to really have seamless integration, which is exactly what Kim spoke about. So specifically, my work within Mass General Brigham is to help support complex care and care continuum, and that's where the post-acute care management work really lies. If we can move to the next slide, I'll start to sort of present when we speak, and I think this is where Kim alluded to in terms of transitional work. You can see in the blue box, our work is around post-acute care management, and that specific blue box is overlaps with acute care, transitional, and that's sort of that bridge that is happening from the acute care to a post-acute, but also could be back to home, and how we're working to bridge that to longitudinal care planning. So I think if we look at this, our post-acute care management team, which can be referred to as a transitional care management team, is really sort of working not only with acute team or inpatient case managers that Kim provided an overview on, working with our social work colleagues in the inpatient space. We really have a lot of presence, a lot of a collaborative interventional support for skilled nursing facilities for our patients within that transition to skilled nursing facilities. And once they're ready to go and from a skilled nursing facility to home or to the community, that is the bridge to also help support to ambulatory care or through the community. And you'll hear in a moment where Marianne will describe further the work that is being done in the ambulatory space. Our complete focus is around seamless care continuum work. And this work really does align to population health. And so this is a way to allow for a lot of integration that allows us to be able to work and really keep the patient at the center. Next slide, please. So our post-acute care management team, I think, again, we noted it as transitional care management, but within our Master and Brigham structure, it is called post-acute care management. Our full focus is to ensure safe, timely, coordinated transitions for Medicare ACO. Now, more recently, it also includes teen patients, ensuring that as patients are moving through the continuum from hospital to the post-acute setting, we're promoting optimal recovery and reducing avoidable utilization. In terms of the ACO, this is, I think, when we speak about it, I should say, we're right now focused on ACO and teams, but I think what we're trying to ensure is that this framework and the work that we're doing can support any value-based work in the future. So if in the future state it includes other value-based contracts, we're ready, we're able to support, but our current focus is, again, the Medicare ACO, which is really the focus, and again, newly the teen patients. As a whole, our post-acute care management work manages our Master and Brigham SNF Collaborative, our 3-day waiver program, and we work to help support the transitional care management work, not only in the hospitals, but also in the skilled nursing facility setting. Currently, we're helping to support and collaborating with SNFs all across Massachusetts and New Hampshire. In addition to our presence in the hospital setting, and of course, ensuring that there is transitional planning and support to our communities and our Care Compass team, which we will again hear shortly. Next slide, please. So in terms of our post-acute care management, really our goals is to enhance quality of care and optimizing SNF utilization. And aligned with the case management scope of work, really it's ensuring that we're providing the right care at the right time, at the right place, whenever possible, ensuring that patients are discharging home. And I think this is where Dr. Hirsch's presentation prior to our really sort of hit the nail, which is trying to ensure that we're doing the right thing for patients, but also looking at cost of care, ensuring that we're doing the right sort of whole as opposed to for that individual point in time. So we're leveraging our collaborative networks, and that is mostly our post-acute collaboratives, which more recently also include our home care collaborative, and we're doing a lot more with home care. Within the SNF setting, ensuring that all is doing to support the optimal recovery of our patients, and that includes a SNF length of stay and lowering hospital readmissions. So if patients are leaving skilled nursing facilities and are returning to the hospital, we want to understand why. What are the reasons, and can we do more to be able to support return to hospitals or the ED? So our transitional care managers are ensuring that there is continuity across the care continuum, although episodic. And so I think that's really important. We're not following patients through the continuum of care completely. We're episodic based on what is happening in the hospitals, transitioning to the post-acute setting. And then at that point, there is a small intervention post-skilled nursing facility discharge, but we're not following patients longitudinally. They serve as a patient and family advocate, and also serve as a support, ensuring that Master and Brigham presence and care continues within the post-acute space. They're applying length of stay decision support tools for patients in skilled nursing facilities and trying to facilitate smooth transitions of care, not only from hospital, and that is through handoffs, that is through bidirectional communication with a skilled nursing facility, but also when patients are leaving skilled nursing facilities. And that could be with home care agencies and trying to ensure that care is scheduled, set up, and patients will be seen, but as well our primary care. Lastly, in order to do all of this work, we're working very collaborative with our skilled nursing facilities to ensure that there's partnerships, there's collaboration, there's bi-directional communication. And really, the people in the skilled nursing facilities facilitate all of that. Next slide, please. So our newly supported work is in inpatient hospital admission. So our inpatient transitional care management is new. It's a new scope that really trying to strengthen transitions of care and coordination by working very collaboratively with our I'll say case management teams, but it's also all that multidisciplinary team within the hospital setting. They're enhancing interdisciplinary collaboration and bringing an additional layer of perspective from a post-acute perspective related to safe discharges, not only for skilled nursing facilities, but home, facilitating post-acute care planning via the SNF Collaborative Network. And again, that is a framework that allows us to be able to have that bidirectional communication. They're identifying high-risk patients to proactively address complex care needs. And so I think this is an element, the more that we're able to proactively help support our hospital colleagues, the more that we can more quickly try to intervene and mitigate some of the barriers that may come up. And that is using a tool through Impact, and you have a little bit of detail in terms of what that is. We're ensuring more handoffs. So it is easier when you know that there's someone that will be following our patients within the skilled nursing facility and knowing exactly who that individual is, and that our care, and again, I say care because our team members are still involved, still engaged, still trying to ensure that the quality of care continues within the skilled nursing facility. And of course, as much as possible, whether home or to a skilled nursing facility, we want to ensure that all of our ACO resources are sort of available or that are viable for patients, are able to support. And that could be a Care Compass referral or front loading our home care or additional community supports. Next slide, please. Our existing role, our SNF TCM role that's been now within our Mass General Brigham structure for a significant amount of years, that is a significant presence within our skilled nursing facilities. They ensure they're working to deliver timely, high quality care. They have presence within the skilled nursing facilities. They're rounding with the patients. They're actually seeing what is happening within the skilled nursing facility and advocating and supporting patients. They're using a MGB specific prediction tool to monitor the length of stay and the progress within the skilled nursing facilities, while also ensuring that they're able to help support barriers that may come up in support care transitions. Additionally, the strengthening of those collaborations allows for those seamless transitions. And again, we continue, whether inpatient or SNF, as I stated before, is how do we continue to connect and ensure that the ACO resources or whatever is possible to support care is available to patients. Lastly, we continue to support through post-discharge follow-up calls. And follow-up calls are really important. It does allow us to be able to understand what is happening once a patient leaves a skilled nursing facility, and any additional impacts or supportive elements that we would have to think through to be able to support. And we'll review a case study that actually a post-discharge call was the right sort of intervention to be able to support a patient at the right time. Next slide, please. So some of the benefits of our, I will say framework, but also our collaborative work with our SNF network and the work that we're doing is allows for coordinated care, on-site presence at skilled nursing facilities, that rounding, that presence that is ongoing, that continues post an acute stay. And actually, one of the elements that I think is really important from a case management perspective is people feel better when they know someone is going to see, someone from your team is going to see your patient when they're leaving the hospital in a skilled nursing facility setting. There's ongoing communication with primary care while the patient's in the SNF if that's needed, and then access to resources. All of that allows for a shorter SNF length of stay because those shared goals are discussed. They are able to be communicated and advocated for. There's higher quality and safety. That collaboration and the advocacy from our transitional care managers continues to allow for ongoing performance monitoring, but also during the time of a patient's admission. And as noted before, all of this work supports any value-based care work. So in the future, we may be doing a lot more in terms of different contracts, but really are trying to support in this similar framework, the sort of ACO and now Teams. Teams is included in the work that we're doing currently as of January 1st. Again, Dr. Hirsch spoke about, I think, Ann Walker as well, in terms of we're going to be really invested in ensuring that we understand what's happening with our team patients. So next slide, please. So this is a SNF case study that gives a little bit of perspective of what is happening within the skilled nursing facilities. And the type of work that is really ensuring that patients not only leave an acute care hospital, but have that added support that allows for additional intervention. So this case, and I actually know the transitional care manager that supported this very long-standing senior transitional care management, supported a 60-year-old female with metastatic breast cancer and brain metastases, admitted to inpatient hospital for failure to drive, weight loss, weakness, and poor intake, discharged to a skilled nursing facility for diet optimization and rehab. So some of the barriers that were in place are cognitive impairment, limited social support, lived alone, had support from a nephew, and so some of the interventions that our transitional care manager participated in was meeting with the patient, and that does allow for trust to be built. Attended care planning meetings, ensured that the 24/7 private care support was arranged before discharge. Post-discharge, the transitional care manager identified that the 24-hour support had been canceled, and there was a impression of unsafe environment. The leverage trust allowed for family engagement to arrange quick interim support. And of course, this was end of week, and that's when things sort of fall, and because you have to do things quicker to make sure that this patient could be supported. So what was done was a coordinated care call with primary care, oncology team, and home care to address all of the safety concerns, ensured medication management to provide that bridge in care, provided ongoing care, guidance with the nephew connected with assisted living options, expedited paperwork to primary care, and then facilitated the conversations with the oncology team. And ultimately, the patient did align to goals and opted for a hospice referral. But one of the elements I do want to highlight about this was that trust that was built in the skilled nursing facility that actually allowed for that call, that intervention, for coordinated care to really create a plan for this patient that may have returned to the hospital and instead transition to a safer environment and hospice care. So next, in the next slide, I will transition it to Marianne. Marianne is going to speak to us about Care Compass. And take it away, Marianne.
Hi, again, thank you so much for having us today and letting us share our end-to-end patient coordination work that we're doing at MGB. You can go to the next slide. And so our program is called Care Compass. We have had ambulatory care management for about 10 years at MGB, and recently, in the last 6 months, we went through an evolution of the program with a renewed focus on our value-based care, ACO patients, and really trying to target and harness the program to really work with our highest complex, highest utilizing patients with the ultimate goal of guiding better improved outcomes and more days at home for the patient. And the principles that this program is embodying now is really coordinating wraparound care in the outpatient setting. So really focusing on the patient when they're at home, ensuring that they can remain stable by anticipating and acting on any risks that we're able to find before they happen. So really trying to reduce any issues so that we can reduce the need to actually go to the ED and be admitted. And then really the stability at home is really our renewed focus. Next slide. And so what we're doing, as I said, we're ambulatory and team-based care. We really believe, and going back to the quote that Kim said, really believe that problem solving as a team is really the right way to be able to wrap around these patients. We're a regional model for coordinating care. And we believe that this will be, we can be more agile, more responsive, and scalable with our approach. Improving patient outcomes, so doing proactive management of chronic and complex conditions across all care settings. And the key here is really meeting patients where they're at. We were predominantly a primary care embedded program. And with the evolution of this program, our teams are now more agile and nimble to be able to get out into the community, into the home, into the inpatient setting, and into the ED to be able to collaborate more closely around the patient discharge decisions. We're expanding our patient access. With the transition to this new regional model, we believe that we'll be able to serve a broader pool of high-risk patients over a larger geography. We have had a renewed focus on looking at our quality and outcomes reporting so that we can understand through standard workflows, shared goals to have a stronger performance tracking. And we believe the redesign of this program will really be able to ease the burden of our system by better supporting our primary care clinicians, helping to reduce inpatient burden by reducing inpatient admissions and alleviating capacity challenges. Next slide. And so the way that we're doing this, the Care Compass program falls under MGB's Department of Population Health. And what population health is really focused on our value-based care patients, our ACO patients. And we've spent the last year really redesigning and honing the way that the PHSO is going to support our system by developing programs earlier on to help slow our patients' progress to complex medical stage. So in the past, Care Compass was the care coordination program that would serve all patients with any type of need. What we've done is we've added both at the prevention and maintenance level of primary care, really looking at risk capture, looking at our quality measures, really addressing our SDOH needs at that preventative level. And then we've included and added new chronic care management programs around chronic kidney disease, dementia, behavioral health, and cardiac, kidney, and metabolic. We've also put into place a transition of care program for post-discharge, which was help us to reduce readmissions for patients that are not at the level of complex care. And then Care Compass really falls sort of in that middle where we're taking care of the patients that are highest risk. Very complex, multiple chronic conditions, co-occurring behavioral health issues, and high ED and inpatient utilization. And that's where this program is really intervening. Above us, we have a couple of other programs, ICMP Plus, which is a program that's really suited to our Medicaid ACO patients. These are patients that are not engaging in traditional ambulatory care. And so we are bringing our care to the home with nurse practitioners, social workers, and nurses to really coordinate that care for the patients at home. And MGB just launched a new duals eligible program as of January 1st to really serve our dual eligible population. And throughout our whole continuum is our relationship and connection to our palliative care colleagues and ensuring that we're having those right goals of care conversations at the right time. Next slide. And so, as I said, we've transitioned to a true team-based model in Care Compass, where we have sort of the patient and the provider at the center. And we've added a new role to the team called a coordinator, which is a non-clinical role that are really acting as sort of what I call the air traffic controller, really helping to take on those administrative tasks from our clinical teams, helping to coordinate regular outreach for the team. And then the team also includes nurses, social workers, pharmacists, and community health workers. Nurses with the traditional care management role of clinical assessments, care planning, ED diversion, medication management, education, symptom management, and really helping to educate patients around their quality gaps and making sure that they can get in to get those closed. Our social workers play a key role in our behavioral health assessments. Greater than 50% of the patients enrolled in our program have a co-occurring behavioral health issue, really helping with that symptom management and really helping with our serious illness conversations. We have pharmacists that support our patients with very complex medication regimes, med titration, and med education. And then a team of community health workers that are really looking at the SGOH gaps that our patients have and addressing those social barriers. So having a multidisciplinary team that is working to top of license and expertise, we believe can wrap around our patients in a way that we couldn't before with the ultimate goal of keeping them at home. We also have continuing relationships with our specialty providers and our community organizations so that we can make sure that we're getting the patients connected to the right services out in the community. Next slide. And so, as I said, how the team would collaborate, we've got some key functions of the program, and it really is sort of who are the patients that are being referred by the providers or our inpatient colleagues? Are they appropriate for the system, for our program from the system? The teams do intensive care plan management. So assessing the patient needs, identifying patient-centered goals, creating goals of care, and really managing to those care plan goals with the patient. We also do post-discharge follow-up. So when patients enrolled in our program are discharged from either the ED, inpatient, or SNF setting, our teams follow up within 48 hours of that discharge to sort of ensure that the patients are settled and stable at home. And then we intensely follow those patients for a course of 30 days to ensure that, that the patients don't readmit within that time. As far as patient activity and outreaches, the teams are all working with the patient, whether it's a new patient outreach, understanding when a patient in real time is in the ED or is getting ready to be discharged from home, that our teams are collaborating with both our ED and our inpatient colleagues for discharge planning and for a warm handoff. We regularly outreach to our patients, at a minimum every 30 days, but in some patients, we're talking with them weekly. We're doing home visits, we're doing it telephonically, or we're meeting our patients when they come in to a primary care appointment. We help with follow-up reminders, we help with appointment confirmations, we help with transportation needs, and SGOH follow-up. Our teams huddle every single day. So to address urgent issues, to understand who's coming into a practice, who might be in an ED or an inpatient setting that we need to go see. The teams are sharing updates, barriers, challenges, and most importantly, successes that they're having with the patient. We also do a weekly huddle to look at who are the new patients referred to the program, who need to have outreach and an assessment done, and then who needs a reassessment. And then monthly, the teams are getting together to do in-depth patient reviews. Who are the patients where we're unable to move our care plan goals forward? Who are patients that might be ready for graduation for a program, and really focusing on that. And then most importantly, having standard documentation within our Epic record, and understanding sort of what are the needs, what are the tasks that need to be done with the patients. And it allows our system colleagues to be able to see what we're doing with the patient, what goals we're working on, and that we can collaborate more closely. Next slide. And so, we really thought long and hard about what are the care management levers that we can use, both pre-event, at an event, and then post-event. And so, things like clinical optimization. Do we have care plans? Are we reaching out to our patients in a regular way? Are we connecting and communicating with our primary care providers around what's going on with the patient? Rapid access and care substitution. So really understanding what are the tools within our system that our teams can leverage from, our urgent care centers. What can our urgent care centers do? When are they open? Working with our primary care providers on access. Can we get a patient in for a same-day appointment? If they do go to the ED, can we participate in an ED conversation, coming to the ED, working with the inpatient the ED case managers or the ED providers to see whether or not we can set up services and supports at home to maybe, make a decision. Otherwise, we would have admitted the patient, but we feel more comfortable wrapping around with our ambulatory team, sending that patient home. Most importantly, and what I'm really excited about, is the renewed focus on care transitions and post-discharge support. So working very closely with Kim and Trancy on getting our teams to be able to communicate real time when a patient is admitted, and then at the time of discharge, and having our teams participate on the floors, meeting with the family, meeting with the patient, so that we can have the best discharge plan that we can for the patients at home. And then behavioral social support activation. So having the social workers and our community health workers wrapping around our patients and continuing to address those needs on an outpatient setting, because we know that they are high drivers of ED and inpatient utilization. Next slide. And so just sort of at a high level, this is our vision for our engagement between our inpatient ED colleagues and Care Compass. So having our care teams be notified of the event, having our care teams reach out to the ED case manager to determine appropriate on whether we should be doing this as a telephonic communication through our Volt system, or if it made sense for our teams to actually go to the ED and participate face to face. We have the ability to potentially talk with that family. I think Kim, you had mentioned, families sometimes leave, or Dr. Hirsch said sometimes leave the patient there. But we have a strong relationship with the patient and family. So if we can come and actually talk with the family and help do some of that translation. And also we get to bring the longitudinal lens of the patient that an ED provider otherwise doesn't have when they're seeing the patient for the first time. And then being able to have that decision. Is it right for the patient to be admitted? Is it right for the patient to go home for that warm handoff? But if the patient does get admitted to the hospital, then working closely with that inpatient case management team and follow the patient while they're inpatient, understand, are they going to go to the SNF? Are they going to go home? So that we can pick that patient up on the day of discharge. And so we're really excited. We've launched this sort of renewed approach at Newton Wellesley in December. And I'd love to share sort of a patient story on how I think we've made a really positive impact. So if we go to the next slide. So this is a patient story on our collaboration. So as you can see on the left-hand corner, the patient snapshot. A very complex patient, paranoid schizophrenia, hypertension, obesity, a new cancer diagnosis, severe social determinant issues. They were enrolled in Care Compass back in October of 2024, and they have high risk of readmission. They had an event at the end of November that the patient was admitted with an ICU stay. We understood from that admission that there was high risk for medical, psychiatric, and social destabilization upon discharge. So Care Compass in action. So what we did was proactively coordinated an intervention across the setting. So having our Care Compass social worker, who had been working very closely with this patient on the outpatient setting, work with our inpatient case management real time to help activate the healthcare policy proxy, get the patient family engaged because there was a strong relationship with that patient. We were able to coordinate with Social Security and community supports so that when the patient was ready for discharge, we had those all set up on the outpatient side. The nurse followed up post-discharge with all the medical concerns that the patient have, doing a post-discharge assessment and reinforcing all the outpatient follow-up. So really being able to take that discharge plan and actually activate on the outpatient setting. Our coordinator was able to support the PCP, making sure that we had the appropriate insurance alignment. We were able to close any logistic gaps that sometimes derail care because we don't have either the benefits or the prior auths in place to get the services on the outpatient setting. And then between the inpatient team, the cancer center team, and our social worker aligning, we were able to get transportation to the oncology visits, that we did joint outpatient follow-ups. We really worked with the family to encourage them to attend the visits with the patient to be able to understand what the care plan was for that patient. And what would the outcome? So there was that one inpatient admission, as I talked about, and then there was a brief ED visit. It was directed by the cancer center. They felt strongly that the patient needed to go and be evaluated at the ED. But what we were able to do is not readmit that patient because we had remarkable community stability wrapped around the patient. And, when we reflected back on what would happen if we didn't have that tight collaboration between inpatient and outpatient, we believe truly that the trajectory without this coordination would have ended up with fragmented discharge planning, that we don't believe that the patient would have been able to get to their oncology appointments or their primary care follow-up appointments. That the patient, we don't think, would have adhered to their medication that would have led to psychiatric destabilization. The family really having not been engaged with decision-making around the role, that the ED would have become the default access point for the patient. And we truly believe that there was a high likelihood of rapid readmission for this patient. And so, it just taking away from what we just all talked about was intervening early and often before a clinical crisis, hopefully in meeting patients where they're at, we believe has a real benefit. Cross-team collaboration through verbal handoff, electronic exchanges, and alignment is really key. Closing the loop across the transition, so being proactive and intentional with our bi-directional communication between the teams, especially during times of discharge, are critically important. Identifying and addressing the social barriers of needs really is a first order to reducing risk, and then clear documentation so that everybody involved in the care has a shared understanding of the continuity of care. That's it.
So we'd be more than happy to take questions at this time, or any comments or suggestions.
Great. Thank you. Thank you to all of you. It was a really wonderful, very clear, lots of explanation, and I kind of see it as like a real life example of how to use case management, social work to the optimum and optimal ability across the care continuum. So there's quite a number of questions in the chat. I'm just going to go over to them. So thank you, everybody.
Sure, I can see some of them.
Okay, so let's just see. So the
Local educators.
Exactly.
We do have a wonderful system educator, and I believe she's on the participant list today. She's absolutely phenomenal, has been a case manager for quite a long time and has extensive knowledge regarding the practice across the sites. She has helped us tremendously develop some standardized content for onboarding. She goes out to the local entities across MGB. She's in her car a lot, but also created a lot of content that she puts online at our central MGB Vitals site for all team members to access. So we do have Janelle as our system educator, and also Mass General and the Brigham have their own local educators. So that has also been extremely helpful. In terms of all post-acute settings, Tracy, if you don't mind tackling that one.
Yes, of course.
That was, do you cover all of them? Do you follow them all? Or what, I think what it's asking too is which ones you
Yeah,
follow.
so great question. We follow all patients within the MGB SNF Collaborative, which in current state as of right now, it's a little bit over 50 facilities. A couple, or I should say a few in New Hampshire, the rest are all in Massachusetts. But I think what's really important here is it's an ongoing evaluation, ongoing sort of assessment of where our patients are going. And so if we're seeing patients are going to facilities that we may not be covering, it is going to be on behoove us to start covering those facilities. So I think it's really important to sort of understand that we're working within that number of facilities, but it could change based on where our patients want to go.
Thank you, Tracy. The next question is, how are you integrating the health plan teams to this integrated continuum of care programs?
Yeah, that's a great question. So as Tracy reviewed, a lot of the programs that we have deep integration with are the Medicare-based plans, also Medicaid-based ACO plans. As you know, everyone here on this call is navigating how do we continue to grow and expand based on different expectations of the various health plan team members. And that's an ongoing process for us, whether it is an electronic integration. We have Epic across MGB, so a lot of our health plan colleagues do have some consolidated access to Epic for individual patients that they're following, and we continue to maximize that. So working closely with our digital team members, but also different health plans have different care coordination programs. Would love to integrate more. We have been reaching out to them on an individual basis. Some have case managers or social workers that follow high-risk patients and or like readmission programs. We'd love to hear more about that. I have found that it's hard to keep up with some of the changes that are occurring across our healthcare delivery systems at this point in time. And you know, our process has completely been revamped, and I know some of their processes have been, you know, evolving over time. So that 2026 is definitely our opportunity to re-engage with those health plans, including our own. We have an MGB health plan as well. Re-engage and incorporate them into this foundational model that we are developing. So that's a complex answer, Evelyn, for your question. I hope I answered that. We do have Epic banners that display and identify patients that are in any of our ACOs or our MGB ACOs, whether that's Medicare, Medicaid, in any of our teams programs, and I'm sure there'll be many more by the time we're even done with this call. They keep growing and evolving, but we do have Epic signaling internally for our team so they can stay in tune to what's happening. As you have probably experienced, the participants on this call, you can have an assignment of 20 patients, and each of the 20 has a different ACO or PCP or group or different integrated network that we have to work with for post-acute planning. So it's getting extremely complicated for our frontline team members to understand what these groups are, first of all, and what is required of them on the inpatient side to maximize efficiencies and quality. So we're trying to make it as easy as possible through our signaling processes in Epic for them. It's definitely ongoing and working very closely with our digital teams.
Thank you. So Catherine asked, I am interested in learning more and obtaining information on your program. This is a phenomenal program. I would like to learn more and follow up with you.
Definitely.
There's 105 people in here today, so good luck. No, it really is great.
That's okay.
Thank
We
you.
like the feedback in the evolution. And
So
Evelyn
Evelyn,
mentioned,
expanding her question, yeah.
discharge to home. Yes, we have this wonderful structure for managing patients in our post-acute environments. Our goal is also to discharge home when absolutely that is our first choice. However, the patient defines as a home setting, where it's assisted living, group home, or whatnot. We have a wonderful group of home care team members, not only our MGB owned home cares, but many networks. You've heard about some of them today. So that's also our number one priority. Most of our patients go home, majority of our patients across the acute care hospitals. So that is our first effort to get them there. What we have found, and I'm sure all of you can relate, patients have social determinants of health that are very challenging to navigate and require a lot of follow-up, not only upon the initial discharge out of the hospital, but once they get there, making sure they have the utilities that they need, making sure they're getting the food that they need, making sure that the plans that we set up at the point of discharge are still appropriate for the patient, and to reduce that opportunity to come back to the ED. So that is definitely maybe a different presentation for a different day, but that is definitely an area we are focusing on next, and how to make sure the patients are safe and successful with their home plan.
Well, Nicole's question is pretty complex, I think. Going back to the AMPAC scoring system, which discipline within your facility is utilizing your tool therapy, nursing, because that's a question. We attempted to integrate this tool in our acute trauma stroke center through our therapy department, but had issues keeping it going. FYI, we are an academic facility.
Yeah, those are great questions, and I'll toss it over to Trancy in a minute. But at our acute medical hospitals, the nurse, the RN, who is the primary nurse for the patient that day, does complete the AMPAC scoring, the initial AMPAC score assessment. It is then seen by our case management team members, the attending physicians, our therapy team members, and that is our starting point. It can be reassessed at any given time, but it is another tool in our toolbox to use to manage or create a very customized therapy plan while they're in the hospital, but also to coordinate that when they are ready to be discharged. But handing it over to Trancy in regards to the management and the SNFs.
Yeah, I'll say the way that we approach the AMPAC is actually while the patient's admitted, our inpatient transitional care managers are looking at the AMPAC score and are looking to see, whether that is a trigger point of whether they are going to be following a patient a little bit more closely than not. And so they use that again as a starting point, but this is a tool, as Kim indicated, a tool because their ongoing communication with the rehab therapy and our case management colleagues to allow us to make sure that we're understanding what the plan could be. Additionally, that information is used once the patient is transitioning by our skilled nursing facility TCMs as a sort of guiding post. Generally, they are referencing the physical therapy AMPAC score.
Great. Thank you for that. Excellent. So we have 2 more questions, and we're going to It's 9 after 11. We're going to wrap it. We hope at 11:15 if we're able to. So the next question is: your structure is very structured and well encompassing. What are your approaches in filling in this role? Are there any challenges and opportunities with retention and staff turnover?
Marianne, do you want to take that from a care compass?
Yeah, so for the ambulatory, we have a full team. So there's roughly 200 staff that across the entire system that really focus and work directly with our primary care practices. And we have had luck in filling the positions and keeping them in. We're trying to make sure that we offer professional development opportunities and other trainings as an opportunity for folks to be able to have sustainability in the role. But we have been able to recruit. We typically recruit nurses that have care management experience. We've got a lot of VNA or home nurses, nurses that have transitioned from the inpatient setting to the outpatient setting. The same with our social workers, being able to share those learned experiences from both inpatient and outpatient.
Thank you, Marianne. So the last question is there a structured onboarding process?
That's a great question. And I can speak for the acute care hospitals. We have developed content for standardizing the onboarding process for inpatient case managers at the acute medical hospitals. That includes, all the competencies of the content. We use different subscriptions for online learning. From another professional organization, we have all the content that Janelle, our system educator, has created. Also, the local hospitals have a portfolio of information that they like to provide to the case management team members related to their specific hospital and local community, which is very important. We are also training preceptors and making sure that they have what they need to precept new staff. And probably similar to what everyone on this call has seen, it's no longer just orienting an experienced case manager to a new setting. It's orienting a new nurse to the discipline and subspecialty of case management, or orienting a new social worker to the discipline and expertise of social work. So it's the education frameworks have changed just a little bit. It's more intense. Also, we're seeing quite a few retirements on the inpatient side. So trying to navigate that and also create a pipeline for ongoing recruitment and development of our case managers and social workers. Marianne, anything to add from the ambulatory side?
Yeah, so as I said, we've done some redesign of the program. And so we've been fortunate enough to be able to talk with Janelle about sort of the work that she's done and trying to make sure that we're collaborating around that. But I anticipate over this next year, similar to what Kim has said, that we're going to be relooking at our structured standard training that we've had in the past and revamping it around this team-based model. And we've been working closely with our organizational development team to be able to help put that into place. So we're a little bit behind Kim, but we've got some work to do. But the plan is to have that very structured, ambulatory care management modules for us to be able to train our teams on.
Well, thank you to all of you. I'm sorry.
June, can I
we have
just mention one thing? That's okay. I saw a question about some of our data. We're developing comprehensive data sets, looking at our data, our outcomes, with balancing countermeasures regarding readmissions and length of stay, working very closely with our digital and analytics colleagues to make sure that our ongoing path of evolution is creating the outcomes that we want and need. So we are a very data-driven organization and following that very closely and accountable to that. But thank you for having us today. Reach out at any time.
Thank you, Kim, for adding that. That was important for all to hear. And to each one of you, Kim, Trancy, and Mary Ann, your journey is a great learning experience for all of us, and lots of important strategies and looking at your successes. And we really appreciate the time that you gave to us in our community and to the people from all over the country. Thank you so much.